Good evening, everyone. Good evening, dear all. This is Dr. Radhika Krishna Patil. Good evening, everyone. Good evening, dear all. This is Dr. Radhika Krishna Patil, renal pathologist. But today I got the opportunity to moderate this session of this wonderful, renowned hepatopathologist, Dr. Nalini Madam and Dr. Anjali Gupta Madam. So, Dr. Anjali Gupta Madam, she is Principal Consultant Histopathologist at Max Super Speciality Hospital, Saket, New Delhi. We are eager to hear you, Madam. Anjali Madam, over to you. Thank you.
Hello. Your voice, your
Hello,
mute.
Nalini ma'am. Good evening.
Good evening. It's a very nice initiative. We must congratulate you on that.
Thank you, ma'am. Thank you.
Yeah. Same here. I'm congratulating you both.
No.
You all. Yeah, it's a long time.
No. It's a honest effort and getting well appreciated and able to do something. And you all are there. That's why it's like cherry on the top. Otherwise, alone we cannot do anything.
Yeah, very nice.
Okay.
Yes.
So, I think I shared that video.
Yes,
no?
yes, ma'am. It's live, so we'll go on. Himanshu ji.
This is mine.
First,
Okay.
First is Dr. Nalini's actually. So you can.
No, I think we have to sit like maybe you can play any whichever is okay.
Yeah.
Shall I start?
Okay. Yeah, you can.
Yes.
I'll just cancel my video. I mean, just.
I'm Dr. Anjali K. Gupta, and I'm going to speak a bit on post-transplant lymphoproliferative disease and graft versus host disease. Well, post-transplant lymphoproliferative disorder includes a wide spectrum of diseases. It ranges from benign proliferation of the lymphoid tissues to the frank malignancy with aggressive behavior after solid organ transplantation and in hematopoietic stem cell transplant cases. Clinically, post-transplant lymphoproliferative disorder can manifest either as localized lesion or as a systemic disease. Now, the risk factors for PTLD, or post-transplant lymphoproliferative disease, is solid organ transplant. In solid organ transplant also, the amount of lymphatic tissue in an allograft is the most important factor, as the incidence of PTLD is highest in cases with multi-organ and intestinal transplant cases, where this lymphatic tissue is most prominent, or amount of lymphatic tissue is more in these organs. Another thing which is important in solid organ transplant cases is the degree of immunosuppression, which could be prior to the transplant or during and after the transplant. Allogenic hematopoietic stem cell transplant, well, the incidence of PTLD is primarily related to the degree of HLA matching and with consequent introduction of the T cell depleting agents prior to transplant. So the incidence of PTLD is low with the use of non-specific broad lymphocyte depleting agents like T and B cells. Thirdly, the cumulative immunosuppressive burden will come to these factors, and Epstein-Barr viral status. But the role of immunosuppression is that, like I had said previously, the T cell depleting agents which are used in solid organ transplants lead to a decline in the T cell immunosurveillance, which leads to an uncontrolled B cell proliferation. This impaired immunosurveillance is also responsible for infection-related malignancies, as we see in the HIV-infected patients, and presence of previous exposure to immunosuppressive loads during the primary treatment of the disease for which the transplant was done is an independent risk factor for PTLD evolution, usually seen in the renal transplant cases. Now, EBV infection. So we all know that most adults have been exposed to EBV with latent viral infection, usually controlled by natural killer and T cells. Hence, the EBV naive allografts, recipient children, they are at a higher risk of developing post-transplant lymphoproliferative disease as compared to the adults. And impaired immune responses to primary and reactivation EBV infection with immunosuppression can give rise to PTLD or post-transplant lymphoproliferative disorders. Now, in addition, Epstein-Barr virus has an oncogenic impact. This is due to the lack of immune recognition due to heavy immunosuppression prior to transplant, during and after the transplant, and which can lead to the EBV to induce highly regulated growth transformation with expression of all its growth-inducing proteins. Potent oncogenes like LMP1 and LMP2 are induced via the environmental factors. EBV-induced proliferating cells as well as EBV variant HLA type combinations may permit these proteins to bypass the immune control and go unrecognized. Also, the growth alterations, growth alterations with the right level of expression of T target and viral and cellular mRNA are to be taken in account. Now, in addition to EBV positive PTLDs, we also have around 50% of cases which are EBV negative. So they usually develop more than 1 year post-transplant and are having these cases. CMV or other viral infection associated, it could be due to the prolonged immunosuppression or allograft-driven persistent antigenic triggering, and hit and run hypothesis by EBV has also been held responsible, where the EBV initially, then it disappears from the system, and hence EBV is PTLD cases, which after in the patient, that is hit and run hypothesis. So now PTLD in liver transplantation develops in 2 to 5% of liver transplant recipients. It has a high incidence of 5 to 10% in children without antiviral prophylaxis for EBV, and usually presents in the first year of transplant. Extranodal involvement is common, and GIT is the common site. 10 to 15% of cases, the allograft, that is the liver, is involved. And most PTLDs occurring in liver allograft recipients are derived from the recipient's lymphoid cells. But the donor or donor and mixed recipient origins are also known, which is usually negative for EBV infections. Now, according to WHO 2017, there has been a classification of post-transplant lymphoproliferative disorders into four main categories: non-destructive post-transplant lymphoproliferative disorders, polymorphic PTLD, monomorphic PTLD, and classic Hodgkin's lymphoma like PTLD. Now, the non-destructive PTLD has been classified into further 3 categories: plasmacytic hyperplasia, florid follicular hyperplasia, infectious mononucleosis like PTLD. And we'll go and see the microscopic pictures. This is one of the non-destructive PTLDs we had earlier discussed, and we have said plasmacytic hyperplasia. So we can see here that this is the low power view and this is the high power view. We can see that there are plenty of plasma cells. There's a plasma cells. The higher power view confirms it, loss of plasma cells here. Now the second variety is the florid follicular hyperplasia. This is a section of the tonsil where we can see this follicular hyperplasia here, lots of follicles reactive follicles, benign looking, and IHC for EBER, that is Epstein-Barr virus, here shows positivity in all these cases. Then infectious mononucleosis like picture is also seen. This is also a microscopic section from the tonsil. And here we can see lots of lymphoid cells, and the higher power view shows immunoblasts. There are a lot of immunoblasts here. Now, this is the second category of polymorphic PTLD. The polymorphic PTLD usually presents with a mixed inflammatory background with presence of multiple immunoblasts. These are the multiple immunoblasts which we are seeing. The higher power view showing lots of necrotic activity, lots of apoptosis going on in there, along with immunoblasts. This is the third variety, or the monomorphic PTLDs. Monomorphic PTLDs like B cell specific PTLDs. In B cell PTLD, diffuse large B cell. Here is this is the picture of the diffuse large B cell variety of monomorphic PTLD. This is the higher power view. Now, in the monomorphic variety only, the plasmablastic and Burkitt cell lymphoma types are also been seen. And lastly, this is the classic Hodgkin's lymphoma like PTLD. So a polymorphous background with presence of Reed-Sternberg cells, and all these cells coming positive with IHC for CD30. Now, hepatic PTLD is something which is limited to the liver. Here we can see that this is a portal tract which is infiltrated by many plasma cells, lymphocytes. Few eosinophils are also seen, and it doesn't have an interface activity. It's a limited interface, and on IHC there is a kappa chain restriction in these plasma cells. So hepatic PTLD usually present as a portal infiltrate. Now, the treatment of PTLD is usually reduced immunosuppression, and it is less responsive. This therapy is less responsive in EBV negative PTLDs. Rituximab therapy or anti-CD20 therapy for non-destructive PTLD, polymorphic and monomorphic diffuse B cell-like PTLDs has shown many good results. And in other cases, which B cell PTLDs, which are unresponsive to rituximab and reduced immunotherapy, chemotherapy-inducing immunotherapy for Burkitt's and Hodgkin's Hodgkin's disease, peripheral T cell lymphoma, and primary CNS lymphoma have been used. Adoptive immunotherapy is usually done in PTLDs associated with the hematopoietic stem cell transplant, and this includes infusion of donor lymphocytes with a particular risk of developing graft versus host disease in the later stages of life. Retransplantation has been very promising lately because it has not been seen to, PTLD has not been seen to recur after retransplantation. And the preventive measure of PTLD is monitoring of EBV viral status or EBV viral titers by PCR or any other method in the high-risk patients. And a sustained viral detection for more than 6 months is a significant risk factor for post-transplant lymphoproliferative disorders. Now, prognosis of PTLD has improved lately owing to new lymphoma-specific protocols and better supportive care, which is available in today's date. Now, next, we are going to speak a bit on graft versus host disease, or GVHD. And I'm going to restrict my talk to the hepatic variety only, because it is a big chapter. I mean, like, it's a big chapter, and it is a complication of hematopoietic stem cell transplant due to infusion of allogenic donor lymphoid cells. And the liver involvement occurs in 10% as a part of the multisystem disorder. And in 1% of cases, we see hepatic GVHD. occurring singularly. Now, it has been divided into acute and chronic cases, where in acute we see involvement by GVHD in the first few months of life, and it affects usually the skin, liver, and the GIT. And in chronic, it occurs usually after 100 days post bone marrow transplant. In addition to the skin, liver, and gastrointestinal tract, it affects the salivary glands, the lymph nodes, the mouth, eyes, lungs, and the musculoskeletal system. However, has been observed to be overlap between the acute and chronic varieties, and the chronic-like presentation may happen before the 100 days, and the acute-like symptoms may happen after the 100 days, which has been defined previously. And, currently, the NIH consensus guidelines proposes 3 diagnostic categories of GVHD, wherein there is either no GVHD, there is possible GVHD, or likely GVHD. It's diagnosed when there is some histological features of GVHD, but additional biopsy or laboratory changes raise the possibility of another disorder, or if the biopsy changes are not definitive but cannot exclude GVHD. Clinical features of GVHD. Hepatic GVHD in particular is jaundice and cholestatic liver biochemistry. Acute hepatitis-like picture is seen wherein the transaminases are raised to great levels. Hepatic GVHD is immune-mediated destruction of smaller bile ducts. And the risk factors for development of hepatic GVHD include older recipient age, female donor cells into a male recipient, use of peripheral blood stem cells, and previous episodes of graft versus host disease. Now, the pathogenesis. The naive T cells and cross-reactive virally induced memory T cells play a role in the immune-mediated reaction against host MHC and non-MHC antigens. Antibody-mediated mechanisms are also involved here. Fast-mediated apoptosis has also been shown to have a role. Now, the class 2 MHC antigens have increased expressions on the bile ducts and hence have increased susceptibility to immune-mediated damage, leading to GVHD, hepatic GVHD in particular. So now there is a spectrum of histopathological changes which have been described in many books. So they have divided the histopathological changes into four main groups: early acute, early chronic, and chronic. In the early acute, there is usually no or minimal change in the bile ducts, whereas in the chronic, there will be a marked bile duct loss. And the other nuclear features, we can always see that there is some withered ducts are seen in acute and early chronic, and some nuclear atypia and pleomorphism is seen in acute and early chronic. And in chronic, it is usually marked fibrosis, cholestasis, mild ductular proliferation, and this mimics PBC. Now, the changes are also seen in the hepatic parenchyma, the early acute having minimal or no change, to the chronic showing hepatocellular cholestasis due to the bile duct loss, and rarely it can progress to cirrhosis. Now, the portal tracts, again, in the early acute, you might get minimal or no change, whereas in chronic, you will get loss of fibrosis and mild to moderate lymphocytic infiltrate in the portal tracts. Well, this is the microscopic picture of a case of GVHD. Here we can see that this is the bile duct, and there is a nuclear pleomorphism here, and withered ducts or senescent ducts are seen here with cytoplasmic vacuoles in the higher part. You can see here cytoplasmic vacuoles, and there is some infiltrate, some neutrophilic or eosinophilic infiltrates going on there. And this is late chronic, wherein we can see that there is a lot of cholestasis here, intracellular cholestasis, and Again here, this is the central vein, and pericentral, some necrosis is seen, some cholestasis is also seen. And these are the late stages of chronic GVHD or late stages of GVHD. Now, GVHD in liver has to be differentiated from sepsis-induced liver injury, drug-induced liver injury, bile obstruction, and chronic rejection. Well, this brings me to the end of the discussion. Thank you.
I'm very sorry
Thank
the
you.
net was not very good while the internet was not very good. The connectivity was not good while we were
Yes.
recording it.
Yes.
Anyway.
No problem, ma'am. The visuals were there, so we will able to appreciate. So can we go ahead with the other presentation?
Sure.
Himanshuji, are we ready? Yeah. Our next speaker is Dr. Nalini Bansal, madam. She is director of renowned institute IGHP, Gurgaon. So we are eager to hear you, madam. Over to you.
Hello everyone, a very good evening to you all. So I am Dr. Nalini Bansal, and today we have been asked to discuss on the topic of recurrent diseases which occur following a liver transplant. Now, this is a very contentious area because this is the major problem by which many of us would deny a liver transplant, because if the disease is going to come back in the in the explanted liver, then also it is a problem. So in this session, we shall be discussing about the recurrent liver diseases following a post-transplant. So the most important question that we are here to answer is, what is the dominant question is, if the LFTs are going up again, then the surgeon and the hepatologist, they get worried because they want to know whether it is some sort of chronic rejection, or this is recurrence of the disease, or this is some other pathology. So that is the time when you are going to get a call from the hepatologist that the liver functions are getting deranged and they want to do a liver biopsy to look for the problem in the liver. So coming to the topic, and that is recurrence of diseases following a liver transplant. The majority of the primary diseases for which a liver transplantation is carried out may recur in the liver transplant. So most of the diseases for which it is being done, they are going to come back into the liver that is being transplanted. Now, these recurrent diseases are the most significant cause of late liver allograft dysfunction. So they generally don't come early on in the transplant, where we do see many kinds of rejection, but in the late period, there is a recurrence of these diseases. The frequency, clinical consequence, and therapeutic options of different diseases of recurrence vary considerably. So the time at which they are going to occur, the clinical presentation that we see in the liver, and the therapeutic options, all of them are going to vary considerably within the liver tissue. The diagnosis of these recurrent diseases are largely based on the histopathological features. And the reason being because their presentation is very atypical, and many of the parameters that we utilize for the diagnosis of these diseases, they are not so often seen in the post-transplanted liver as opposed to the native liver tissue. So that's why we rely mainly on the histological features that are being present on the biopsy tissue. Now, coming on to the diseases that recur after transplant. So as we said, the huge spectrum of diseases can come back in the liver. And of those, the universal occurrence is those of the viral hepatitis, that is hepatitis B and C. This was prior to the era when we don't have these disease-acting modifying drug reagents. So before the newer antivirals were there in the picture, that time we had a universal recurrence of these viral hepatitis. Then followed by that, the next disease that are going to recur are the autoimmune spectrum of diseases, which include TBC, sclerosing cholangitis, autoimmune hepatitis. And then we would also have recidivism of alcoholic liver disease. NASH can also come back in the liver disease in the transplanted liver, and followed by hepatocellular carcinomas and some rare disorders like erythropoietic protoporphyria and sarcoidosis. So coming on to some of the disease recurrence and their features, the first one that we are going to discuss are the primary biliary cholangitis. Now, the percentage with which these diseases recur in the transplanted liver is almost similar for all the autoimmune disorders, and the recurrence incidence of the recurrence rate varies between 4 to 33% for PBC. Now, the autoantibody titers, which we see in the native liver for these diseases, once the liver is transplanted, there is a fall of these antibody titers following liver transplantation, but subsequently a year or so, there is a rise in these titers, which become pseudo-elevated, even in the absence of histological evidence of any liver disease. So if you are going to do an autoantibody titer following a liver transplant later in the course of the disease, then also we are going to find an elevation of these titers, which is actually not an absolute indicator that the patient is having a recurrent disease. So that's why the role of histopathology is very important, because we would like to do a liver biopsy to know whether there is any histological evidence of disease or not. And we are also going to look for other parameters, including in LFTs. Now, the differential diagnosis for these diseases would include all spectrum of the post-transplant diseases, which include acute cellular rejection, chronic rejection, CMVs, and other viral hepatitis. Moving on to primary sclerosing cholangitis. Now, the incidence of PSC is also similar to that of PBC, that is 8 to 37%, and these disease can recur 6 months to 5 years following a liver transplant. The Mayo Clinic has given a diagnostic criteria for the recurrence of PSC, and this PSC diagnostic criteria include a diagnosis of PSC following a liver transplant. So there should be a diagnosis prior to liver transplant that the patient had PSC. Then on cholangiogram, there should be an evidence of the disease, and then histology, there should be evidence of fibrous cholangitis or fibro-obliterative lesion on the biopsy tissue. So this we had discussed, and then moving on to the differential diagnosis of primary sclerosing cholangitis. So these are to be differentiated from cases of secondary sclerosing cholangitis, hepatic artery thrombosis, chronic ductopenic rejection. So all those changes would have a biliary changes in the liver parenchyma, and we need to differentiate them on the histology. Moving on to autoimmune hepatitis, again another autoimmune disease that is going to come back into the liver. And the rate of recurrence, the incidence range from 17 to 42%. They can also occur any time, and the mean time of recurrence is 4 to 4.6 years. So 4 years following a transplant, we could have a recurrence of autoimmune hepatitis. Now, pre-transplant risk factors are that if there is any HLA mismatch, that is a risk factor for development of autoimmune hepatitis. And post-transplant risk factors include the lower level of immunosuppression being given in the immediate post-transplant period, rapid tapering of corticosteroids or discontinuation of corticosteroids following the liver transplant. So all of these are risk factors that the patient could develop an autoimmune hepatitis later on in the disease course. Then some of these patients could develop cirrhosis, and up to 50% of these patients could develop cirrhosis following a liver transplant, which would again require a retransplantation procedure. Excuse me for a bad throat. So the next disease that is going to come back is the de novo autoimmune hepatitis. And this de novo autoimmune hepatitis is basically occurs in a patient who prior to the transplant is not having any autoimmune related disorder. But following a transplant, you are finding a histological picture that is similar to that of autoimmune hepatitis. So it was first described in the pediatric liver transplant in 1998. And this has recently been reclassified by the BAMF classification, BAMF working group, as a plasma cell rich rejection, in which there is a feature of plasma cell rich infiltrate within the liver. And there is also evidence of lymphocytic cholangitis, followed by central perivenulitis and positive DSAs that is being seen in the liver parenchyma. Now, these de novo AIH, they are treated with corticosteroids and azathioprine as the treatment spectrum. Now, moving on to viral hepatitis. So the another sort of disease which are going to come back into the liver are the viral hepatitis. And of these, the recurrence of hepatitis C was universally seen following a liver transplantation prior to the introduction of disease-acting drug reagent, that is the antiviral reagent, that is DAs. Now, this recurrent HCV pursue a more aggressive clinical course following transplantation, with up to 80% of the patient developing chronic hepatitis and up to 30% of them presenting with cirrhosis within 5 years of post-transplant. So, furthermore, in the setting of immunosuppression, the occurrence of viral hepatitis They also increase because the patient is immunologically compromised a bit after transplant. So 2 to 5% of these are going to develop a variant of these hepatitis, which is known as fibrosing cholestatic hepatitis within 6 months of transplantation. Now, this FCH is associated with very high level of viremia, and of which they are very cytotoxic because of this viral load is very high. So they are going to directly damage the liver cells, and these are going to have a very grave course following this viremia. And so there is rapid progression of jaundice, liver failure, and death, and the mortality rate is very high if they are not treated. So just a word about FCH. FCH is an aggressive variant of HCV, HBV related disease. There is massive viral replication, and it occurs early on following the liver transplant. There is rapid graft loss, and the histology is showing you the classical changes of FCH, that is F for perisinusoidal fibrosis, C goes for cholestasis, and H for hepatocellular ballooning. Now, the classical change for FCH is that there is paucity of inflammation. So, very less inflammatory infiltrate is seen accompanying this hepatocellular damage. And if you find a change which is like classical ballooning with paucity of inflammation, then we should also think for changes of fibrosing cholestatic hepatitis. So, there is going to be panlobular hepatocyte ballooning. There is perisinusoidal fibrosis, which is very dominant, and there is marked cholestasis with the paucity of inflammation. And then when you do a viral load, then you find that the viral load into the logs of 4 and 5, then you know that the patient is suffering from fibrosing cholestatic hepatitis. So that was a bit about the recurrence of some of these diseases, and the commoner ones are the, as I said, are viral hepatitis and the autoimmune related disorder. Now, there are certain diseases for which recurrence is less common, and these are the pediatric diseases, like you see for extrahepatic biliary atresia, and you see for alpha-1 antitrypsin deficiency, Wilson's disease, cystic fibrosis. These are some of the pediatric diseases which, once they are transplanted, they are generally said that their recurrence is very rare, or it is not known so far for the pediatric transplanted diseases. So moving on to some of the interesting cases which we encounter following the liver transplant. So we'll discuss some of these cases, and as the time would permit, we can also stop before we do for most of them. So just let me know if there are too many of them, we can stop in between. So the first case is a 70-year-old female who underwent LDLT for AIH related CLD in 2013. Now, following 4 years post-transplant, on evaluation, she was found to be HCV RNA positive, ANA was positive, and the liver biopsy was performed for evaluation to know whether it is an AIH, it's a rejection, late rejection, or it is a HCV related liver disease. So the time when she was transplanted, her LFTs were relatively normal. So there is not much derangement till 17, and then suddenly there was a bump in the enzymes in which AST and ALT were markedly elevated, and then there was also an mild elevation of alkaline phosphatase. And this was the liver biopsy that we got. And at this point of time, the patient was HCV RNA positive, and she was transplanted for autoimmune related CLD. Now, when we look at this picture, there is a dominance of marked lobular unrest that we see. And in addition to this, there is a marked portal infiltrate of the inflammatory cells. And then in addition, we are also finding that there are areas in which the perivenular zone is showing you the necroinflammatory activity with loss of hepatocytes. So when we look at this portal infiltrate, we know there is a moderate to dense infiltrate in the portal tract. And we would like to go at the high part to know what type of infiltrate it is. And in addition, there is also infiltrate in the perivenular region. So looking at this perivenular area, there is a sprinkling of inflammatory cells, which on the high part showed a dominance of plasma cells. So there is a necroinflammatory activity. There is evidence of central perivenulitis, in which there is dominance of plasma cell related infiltrate. Coming back to the portal areas where there is moderate to dense infiltrate, we could identify the bile duct here, and this bile duct is relatively well preserved. And when we look at the portal infiltrate, again, there is a dominance of lymphoplasmacytic cells with occasional sprinkling of other inflammatory infiltrate. And at many places, this inflammatory cells is also spilling into the adjacent periportal interface, into the adjacent hepatocytes with a fair number of plasma cells. We did a C4D and C4D was not significantly positive. It was negative. So the differential diagnosis that we were dealing with is whether it's an HCV related infection, it's a recurrence, though the patient didn't have HCV prior to transplant. So we wanted to know whether this is an HCV related hepatitis that is occurring in the transplant, or it is recurrence of AIH that is occurring because the patient was transplanted for autoimmune hepatitis, or it's a rejection infiltrate that is a late acute rejection. So since there was a dominance of the plasma cells in the infiltrate which is seen in the perivenular region as well as in the portal infiltrate, we know that we are dealing with actually a plasma cell rich kind of a rejection, and this rejection that we are finding is basically related to some sort of plasma cell related activity. The C4D here is absolutely negative, and the patient is also having HCV related, HCV positive. So what we should do, what we are going to look for is, we are going to look for is this a plasma cell rich rejection? We are not going to call it as a plasma cell rich rejection because we have already learned in the previous sessions of plasma cell rejection infiltrate that if the original disease is autoimmune hepatitis, then we are going to call it as a recurrence of autoimmune hepatitis and not as a plasma cell rich rejection. So this is one of the defining criteria where we are going to call it as a plasma cell rich rejection. So if the patient is transplanted for autoimmune hepatitis and you are having this plasma cell infiltrate, we are going to call it as a recurrence of autoimmune hepatitis and not as a plasma cell rich rejection. If the pre-transplant diagnosis would not have been autoimmune hepatitis, then we would have called it as a plasma cell rich rejection. Now, another question in this case was that patient was HCV RNA positive. So many of these cases of autoimmune hepatitis, you would have a false elevation of false positivity for HCV RNA. And in those cases, you are going to look for is your lobular activity. If there is not significant lobular activity, then you are going to take a step back and you are going to also advise for a quantitative analysis for HCV RNA analysis. And if it is negative, you know that you are dealing with a autoimmune hepatitis recurrence. So all these things you have to keep in mind before you sign off a case as an autoimmune hepatitis, and you should do a clinico-pathological discussion. A CPC meeting is a must, and then you are going to come down to a conclusion. So this was a case of recurrent autoimmune hepatitis following orthotic liver transplant, and we know that they are going to mean time of recurrence is 4.6 years that we have also seen for this particular case. So that was the first case. And now moving on to the next case, that is a 58-year-old male post-transplant liver biopsy, and she was being transplanted for HCV-related CLD. Now here we know that the patient is being transplanted for HCV-related hepatitis. Now this was prior to the time when we had treatment with DAs, and this was the liver biopsy that we got following the transplant. Now here, if you look at the low part itself, we know that there is marked lobular unrest. We are finding that portal expansion is not that much as opposed to the lobules which we are finding. There is some little lymphocytic infiltrate within the tract, but there is no evidence of dactylitis or endothelitis. And if you go back at the lobular parenchyma, there are some lymphocytic infiltrate in some of the tract, but there is marked lobular unrest in which there is hepatocellular ballooning, and some of the hepatocytes are also showing you scattered acidophil bodies. So there is an injury to the hepatic parenchyma. There is some lymphocytic infiltrate within the portal tract, but the disease is dominantly lobular in type. So this is a lobule dominant pathology, and there are scattered these Kupffer cell which indicate that some of these hepatocytes have undergone necrosis, and these are being replaced by that. But there is no dactylitis or endothelitis as was seen. So in a given case of HCV-related hepatitis, and there is no fibrosis which is perisinusoidal in nature, no increase in fibrosis, only the degree of lobular infiltrate, lobular unrest with hepatocellular ballooning. So this was a case of HCV recurrence following a liver transplant. And then in the setting of HCV RNA positive, we are going to say that this is HCV recurrence and the patient needs to be started on antivirals for this. But we see this less often with the advent of these disease modifying antivirals. So this is relatively less common in these days. So now this also has been discussed in the previous session. So I'm going to skip this. How you're going to the histological changes by which you can differentiate HCV by this acute cellular rejection. So in HCV, it is basically a lymphocyte dominant infiltrate, whereas in ACR, it's a mixed infiltrate. You don't see ductulitis or endothelitis in cases of HCV, which are seen in cases of AR. And then interface activity could be mild in both of them. Fibrosis, we could see in HCV-related hepatitis, and in HCV, it's basically a lobule dominant pathology where you are going to see lobular dysuria and hepatocellular ballooning. Now, moving on to the third case, a 56-year-old male who underwent transplant for alcoholic liver disease, and he presented 2 years post-transplant with deranged LFTs. He had previous episodes of ACR. So there was history of prior ACR which were modified, which were not biopsy proven, and they were modified with the drugs only. So he presented 2 years following a liver transplant, and this was the liver biopsy. Now we know he is an alcoholic patient, and there is cholestasis that we see. This is a portal tract. The inflammatory infiltrate is not much. Maximally, we can say is minimal to mild. And then on Orsin stain also there is features of some relatively increased fibrosis, which is perisinusoidal and mildly periportal, as was also seen on the MT stain. Now, but this is not cirrhotic as yet, and there is also evidence of these fat vacuoles within the hepatocyte. Now, moving on to the high part, we could find that there is conspicuous absence of bile duct within the portal tract, and in some of the areas, we could find some residual increase in portal fibrous scarring in the areas where there is loss of bile duct. What is conspicuous in this tract is there is absence of significant bile ductular reaction, though there are some little sprinkling of inflammatory cells, but we do not find any significant bile ductular proliferation. Now, in other areas, there is some infiltrate which is lymphocytic in nature, and at the portal parenchymal infiltrate is relatively silent with not significant any bile ductular proliferation, but there is absence of bile ducts within the tract, and as also seen on other smaller tracts. Now, what is happening here is, in addition to fat vacuoles, you are also finding some cholestasis, and in another areas there are presence of these Mallory Deng bodies within these hepatocytes. So what we are basically finding is there are areas where there is some increase in iron overload, Mallory Deng bodies, and also cholestasis in addition to duct loss, and again the high part view of the same. And so this again another area. And on doing an iron stain, there is little increase in iron overload within the hepatocytes. Now, this was CK7 IHC, and there is no bile ductular proliferation, though there is conspicuous absence of duct within the portal tract. So what are we basically looking at is we are looking at a biopsy which is 2 years post-transplant, and patient was initially alcoholic. So what we are finding is ductopenia in absence of bile ductular reaction. So we are still juggling in the areas, is this an alcoholic recidivism or is this a ductopenic rejection that we are finding? So combining all features together, you may not end up finding a single disease on the biopsy tissue, and there could be a spectrum of diseases which can come together because patient has started drinking alcohol again. So you're finding changes of alcohol recidivism in the biopsy. In addition, you're also finding changes of chronic rejection which have now come up in the biopsy. So sometimes you could have a multitude of changes, and you should keep your eyes open instead of just putting your pen down to a single diagnosis. So there are changes of alcoholic recidivism as well as of ductopenic rejection in the biopsy that we just discussed. So if I have time, we can discuss the next cases, or we can just stop down here. So I'm not sure how much time we have taken. So let's discuss the case number 4. She was a 46-year-old female, and she underwent liver transplant, living donor in 2009. Primary pathology was PSC, and she presented 7 years post-transplant with a cholestatic pathology. She also had features of jaundice, deranged LFTs, and itching was also there. And for that, she underwent a liver biopsy. The reason why she underwent a liver biopsy is, as you all can understand, whether this is a recurrence of PSC or there is some biliary pathology or there is this chronic rejection. And this is the liver biopsy of the patient. Now, what we are finding is we are finding the bile ducts here. We are finding the arteries here, there is no significant ductopenia as we see, but the parenchyma is cholestatic. Then there are other areas where there is bile ductular proliferation, which was florid with accompanying neutrophils that indicate that there is bile ductular proliferation, and the ducts are preserved. So we are not thinking on lines of chronic rejection, as was one of the differential diagnoses. And this was also florid biliary proliferation. On doing a CK19 and CK7, 19 is highlighting the ductular proliferation. CK7, there are residual bile ducts here and there within the tract, but most of the hepatocytes are showing you a regenerative phenotype. So this was the pathology, and coming back to the questions that we were asked, whether this is primary sclerosing cholangitis, secondary sclerosing cholangitis, or this is a ductopenic rejection. Now we know from the findings that this is not a ductopenic rejection because there is no duct loss here. There is marked cholestasis in the hepatic parenchyma with bile ductular proliferation. So when we see a spectrum of changes like this, we are basically finding changes of sclerosing cholangitis, which we are not sure at this point of time, whether it is primary or secondary, but we can say that yes, there is this ductular pathology. There is this biliary pathology, there is biliary cholangiopathy. Whether primary or secondary, we are not sure. So this patient underwent a liver transplant 15 days later, and this was the retransplanted specimen that we had. It was all cholestatic on cut surface. There were some dilated ductules, and the prominent finding was that this was all absolutely cholestatic pathology. Now, from the bile ductular areas that were there from the hilum, there were insufficiented bile plugs. There were formation of biliary infarcts that were present, and there were also some changes in the hepatic arteries. In another area, there were evidence of cholangitis with polymorphous plugs within the ductule. And some other areas we could find that there is onion skinning around the bile ductular profile. And then some areas from the hilum, which were like some florid areas, whitish areas from the hilum, there were prominence of these neural tissue at the hilar region, and some of these hilar tissues are also engulfing the ductular profiles of the hilum. So there were prominent neural proliferation at the hilum, which is to the tune that it has formed a mass lesion, and this was basically a neuroma which has formed at the hilum. And because of this neuroma formation, many of these bile ducts are engulfed, and that was the reason why this patient had the picture of sclerosing cholangitis. So basically, this was not primary sclerosing cholangitis which has come up. It was actually a secondary sclerosing cholangitis which was also evident on the biopsy. And this was because of the formation of this traumatic neuroma at the hilar region. So that was the reason why we are finding this pathology. So this was one change which we sometimes need to ask whether it is recurrence. So you need to know the cause of it, then we are going to come back to the final diagnosis. So I think we are already exceeding on the time, and we can skip on to this case. So I thank you all for this patient hearing. So if there are any questions, we can take them up. So to conclude, the disease recurrence represents the major cause of graft dysfunction in long-term survivors. Atypical presentations are very common, and you can have more than one pathology on your biopsy tissue. Histology plays a very critical role in delineating the recurrent disorders. The reason being, you would have an array of abnormal autoimmune profiles. If you are going to do the markers, that is not going to help you in the post-transplant setting. And you need to come down to your histology to tell you that, yes, there is evidence of injury on the biopsy tissue. So thank you so much, and we conclude the session here.
Thank you, ma'am. Thank you for this wonderful class. Actually, I should thank to Nalini madam and Anjali madam for such complex topics, and they made it so simple and with their experience, and also the case scenario, the histopathology pictures. So it was wonderful, and got to learn so many things for me also. I am today not a moderator, but a learning student with great personalities like you. One question is there. How frequent is NASH recurrence on biopsy?
I think, yes, NASH we have not taken up. There was a case for NASH also. Nowadays, they say that NASH recurrence is inevitable if your weight is going to increase. So it is going to come back on the biopsy tissue. And definitely we had seen cases of NASH together with rejection. They do come up provided patient is not regular on his diet and there is obesity. So it is inevitable if the weight loss is not there.
Okay. Ma'am, and how often you come across these overlap syndromes like autoimmune hepatitis, PBC, and PSC, like primary sclerosing cholangitis?
So, like for overlap syndromes, these were previously, they are not in the transplanted liver. Post-transplant settings, we have seen less. But if you talk of the native liver setting, they are very common. And there are like, you can have either the sequential syndromes or you can have simultaneous occurrence of both of them. So there are cases of autoimmune which can later on transform to a PBC-like picture. That is one. And nowadays we call them as a variant syndrome. So instead of like overlap, the recent terminology is we use variant syndrome for that. And there are cases in which they do occur together. So they're not that uncommon. They are relatively common, especially for the autoimmune cases. Even on therapy, they change. So a patient of autoimmune therapy and he's on autoimmune steroids, azathioprine, and you do a biopsy, say 3 years later, and then you are going to find a PBC in that. This PBC is much more common compared to your PSC, which is like more common in the pediatric age group. So PSC with autoimmune is more common in the pediatric groups.
Thank you. My question to Anjali ma'am, is there any fixed panel of antibodies for immunohistochemistry when you see a case of PTLD? Can you just elaborate on that, ma'am?
See, there's no fixed panel of antibodies we use for suspected PTLDs. It's totally based on the morphology of whatever we see. Like, so in like polymorphic and in the non-destructive ones, like plasma cell hyperplasia or plasmablastic or plasma cell hyperplasia sort of a picture, we usually do the non-destructive ones. We usually do the simple ones, CD138, Ki67 and things like that, just to see if it is not lymphoblastic, CD79A, CD20, CD3, all the basic ones, which we do for lymphomas. If it is monomorphic, obviously looks like diffuse large B cell lymphoma. So it's a B cell lymphoma. So we do all the markers which are supporting our diagnosis. The KI is, of course, a very important KI, that is proliferation index. Ki67 is one of the very important factors where we can, further classify the lymphomas. Burkitt lymphoma has its own appearance and its own set of antibodies, IHC antibodies, which are being used for it. So there's no fixed panel, but whatever the morphology is supporting, we do that panel.
Yes. Thank you. Yes, thank you.
Okay, welcome.
Nalini ma'am, how often do we get recurrence of autoimmune hepatitis in your experience, like post-transplant? Yeah.
I would say we have not seen many cases. So maybe less than 10 cases we have seen for recurrence of autoimmune hepatitis. So not all cases have come up. The reason being, one of the reasons being the recurrence occurred later in the course of the disease. So that could be one of the reasons. And second is, we have not seen many of these. We have seen PBCs, but for autoimmune hepatitis, not every case is going to recur.
Yes.
So they say like around 4 to 33%, 37% is the recurrence rate. So probably that's right.
Yeah. No more questions are there.
Yeah.
Thank you. Thank you, ma'am. Thank you once again. You both took out the time and enlightened us. Thank you very much. Thank you, Anjali madam. Thank you, Nalini ma'am.
Yes. Meeting you here.
Yes, ma'am. And thank you all, dear attendees. Because of your attendance only, there is a charm in this course. Thank you very much. Thank you, everyone. Thank you.
Good night.
Thank you.
Good night, ma'am. Good night, ma'am.
Good night.
See you in ISOT. Yes.
Definitely.